Welcome to Back from the Abyss. I'm Dr. Craig Peacock. Today's episode, I would say, was inspired by the work of Nolan Williams. For some of you listeners, you might recognize his name. He was really a leading light of psychiatry, psychiatrist at Stanford, and a pioneer, not just of TMS, transcranial magnetic stimulation, but an accelerated form called SAINT, S-A-I-N-T, which we're going to talk about today. In any case, as you all know, I love podcasts. I love making podcasts. I love listening to podcasts. And I've been seeking out Nolan's work and interviews for the last few years, and I've become increasingly fascinated with his work on TMS. And we did an episode a couple years ago, TMS versus ketamine versus ECT. And we mentioned the SAINT protocol, which is Dr. Williams' invention. But I've just become more and more interested in TMS, and I've been wanting to sit down with an expert. And so this is the first expert interview of season 7. And what's fun about having my own podcast is I can decide who do I want to talk to. And so I put the word out, like, who is the TMS expert of Colorado? And it turns out she's here with me today, Dr. Elizabeth Fenstermacher. Thank you for coming.
Oh, thank you so much for having me. It's really a privilege to be here and get the word out about TMS.
Yeah, thank you so much. Elizabeth is the founder and director of the TMS Clinic at the CU Anschutz at the medical school. And she agreed to drive up snowy I-25 to see me today to record here at my house. So thank you for making the trip.
Oh, thank you. Thank you.
So the audience will have a wide-ranging understanding of TMS, transcranial magnetic stimulation. We'll get into that. So, but just to start with, I'm so curious. I had no exposure to TMS when I was in residency because I was in residency 20, 25 years ago. How did you first get interested in TMS?
My first interest in TMS actually came through a patient. It was during my fellowship. I had been interested in it as a new technology, but even during my training, which was a few years after yours, it was still not widely available yet. It was just starting to be at the universities where I was training. But I was working with an adolescent who was really struggling. He had tried over 15 medications. He had a very dedicated sort of concierge model of care where he got a lot of directed therapies, a lot of different supports, a lot of diagnostic evaluations, and we really thought carefully about how can we help this individual get better. And nothing was working. And it was something that the family had brought up to me is maybe we think about TMS. And at that point, we were going to try anything. So I worked with some of the providers at one of the local hospitals, Mass General Hospital, and they were gracious enough to accept him even though he was not yet 18. And he had an amazing response. Amazing.
How many years ago? This
would have been in 2019. So at that moment, I said, okay, I have to learn this technology. This is different. I've had a lot of patients I've worked with where we've been in this place where, we've gone through medication after medication, and we have just not been successful working on the therapy. They're doing everything they can. They're exercising, they're eating well, they're, taking all the supplements. For those patients, TMS sometimes can offer something quite unique and quite different. Rebecca Allen, who was actually a few years ahead of me in residency and was a recent president of the Clinical TMS Society, she tells an almost identical anecdote about a patient she worked with during residency. So I think most of us have gotten here because we've had that one patient where we had really gotten to the end of what we knew how to do. And then this technology came in and did something miraculous. And I know that's a big word to use. I will share my bias up front. I have never done a treatment that I have felt so passionately about as I do about TMS because of the outcomes we get with patients who have not benefited from anything else. And I know we were speaking about your work with ketamine, and it sounds like you have a very similar experience where this is really transformative for patients who are not benefiting to other mechanisms of treatment.
Mm-hmm. I heard Dr. Williams on a podcast recently say that Psychiatry 1.0 was psychoanalysis. Psychiatry 2.0 was psychopharmacology, and Psychiatry 3.0 is or will be or is about to be neuromodulation. Although I might put in there maybe Psychiatry 3.01 is psychedelics too. And so I do think that we're on the edge of something really exciting. But maybe we could just start with the basics here. What is TMS? We're talking magnets, we're talking pulses, we're talking transcranial magnets going through the scalp. But what actually is happening?
Yeah, it's hard to describe, and so I'm going to go into a bit more detail, and I'm hoping that you've shared with me it'll be a pretty wide range of listeners, that it'll pique everybody's interest, and then for the folks who are diehard physics nerds, they'll have a great understanding, and for the folks who just want to know kind of the basics, hopefully it'll be clear as mud. So TMS, if we take a big step back, on the surface, it's pretty wild that we're able to use magnetic fields to actually stimulate the brain. And so I like to go into why that works, how it works, so it doesn't feel so nebulous. But even before that, I like to define just even what does TMS stand for. So TMS, transcranial magnetic stimulation, pretty much tells you exactly what we're doing in the title. So transcranial, across the cranium or the skull, we're using magnetic fields and we're exciting or stimulating part of the brain. There is a caveat there where sometimes we use TMS to inhibit the brain, though most of our current treatments that are approved are excitatory. There's the migraine approved treatment. That one does tend to be a more inhibitory protocol, but it looks quite different than what we do in the clinic for depression. The development of modern TMS began we could trace it back to specifically Anthony Barker in the 1980s. He was the gentleman who took Faraday's law and he said, I bet I can use this in a way that I can actually make this something we can use to stimulate people's brains. And it uses Faraday's law in two ways. So first, for those folks thinking way, way back to physics, anytime you have a current that's flowing, you're generating a magnetic field around it. And for listeners at home who can't see, I'm moving my hand in a spiral because, of course, it's in that circular pattern around the current. Similarly, every time you change a magnetic field, you're going to generate a current. So he leveraged Faraday's laws in two ways. He took a huge capacitor and he charged it up, and then he discharged a very high current over a very short time span. And that's going to generate a really huge magnetic field that exists for microseconds. It's about the strength of what we use for modern MRIs, about a Tesla. So it's a very strong magnetic field. That leads to some of the contraindications for TMS when we worry about magnet-sensitive materials. And then he did the second piece, which is once we're changing that magnetic field, if we target it to different areas of the body, we can stimulate them with that fluctuating field and generate local currents that will stimulate the areas we're stimulating. Mostly the brain, though there is some new work on peripheral nerve stimulation where we target peripheral nerves directly.
How do you think about TMS in the sort of treatment algorithm of treatment-resistant depression? And let me just say a little bit about how I've thought of it. So pre-ketamine, for me, 2017, I would have said meds, therapy. When that's not working, go to ECT. Mm-hmm. In the last few years, again, I've become such a fan of ketamine, as you know, and I've just seen, again, miraculous things happen with it. But there's been a number of people over the last, 6 to 8 years who didn't get better with ketamine and or stopped working, or they didn't want to do ketamine, and I sent them for TMS. So we're talking maybe 10 or 12 patients in the last 6 to 8 years. And none of them really achieved much. And I know when I first reached out to you, I mentioned this. I said, I want to talk about this idea that I believe that TMS works, and we've seen the data. TMS is getting better. But in my own personal experience, I've yet to have a patient have what I would call as much of a response from it. So I'm wondering, what am I missing? What am I not understanding? Yeah, what happened?
Mm-hmm. And I'm glad you bring it up. It's a really discouraging thing to hear that you haven't yet seen that patient with the big response. In order to understand exactly what had happened, the devil is in the details. So, and off of the podcast, we can always dig through kind of who they were and exactly what the treatment protocol looked like and what was happening for them during it. How TMS is done, I think, makes a big difference. We ask patients who come into our clinic to really make the commitment to do the 6-week course, the 30 sessions, 5 days a week for 6 weeks without missing if possible.
Which is a big commitment.
Huge commitment.
Yeah.
Though it does feel like the way that TMS works, it is that cumulative stimulation until we've gotten into a place where the functional networking has become neuroplastic enough to allow for a new pattern. If we aren't able to get that consistency, if people are doing it and they're missing sessions, they're doing some sessions, if there's big gaps in treatment, I do think that makes a big difference. The biggest thing that I think, though, that drives the outcomes at our clinic has been the combination of psychotherapy along with TMS. Because when we're inducing neuroplasticity, it doesn't necessarily mean it's going to be an antidepressant effect. So there's some early studies that have led me to really think about this in a way of what is happening around you, your environment, the biopsychosocial model really has a big impact on how you do respond to neuromodulation.
Because I think none of the people who I sent did any concurrent psychotherapy during it.
Yeah.
Yeah.
And that may be a piece, a really important piece to ask people to add on, because I do think it makes a big difference. There's some work on SSRIs that suggests that if you give children or adolescents SSRIs when they're in an aversive environment, it actually sensitizes them to that environment. It makes them, it makes them more neuroplastic, and it tends not to be particularly helpful. I think the same thing can happen with TMS. We're giving them the neuroplasticity similar to SSRIs when SSRIs work, or ketamine when ketamine works. We see, if we look at this molecular level, the increase of the BDNF, that brain-derived neurotrophic factor. We see the synapses becoming healthy and, bushing out and looking more tree-like. It does seem like what happens during that period really, really makes a big difference on how people feel after it.
Mm-hmm. Yeah, you had said before we started recording that you might think of TMS more as a neuroplasticity treatment and less as like an antidepressant treatment per se, but allowing the possibility for health.
Yes.
Yeah.
That's where my thinking over the last several years has gone.
Now, I think that's true with psychedelics, and I think that's true with all of our treatments. But that's an interesting way to think about TMS, because I had thought of TMS, okay, these pulses of magnetism and these currents in the brain are going to pop people out of depression. But right, if you think of it more kind of the way I think of ketamine, I think ketamine does have strong antidepressant effects, but I also think it has these sort of pro-neuroplasticity, pro-learning, almost like resourcing people's psyche, their ability to cope and deal with overwhelm. What kind of psychotherapy do you recommend, or do you do concurrently with TMS at your clinic?
So in our clinic, we are able to integrate behavioral activation and sometimes some short-term therapeutic techniques from CBT or DBT, along with the direct care that we do. So we have people come 5 days a week, and then they'll meet with one of our supervising physicians and or one of our residents at least once a week to make sure they're making progress. And then we set the behavioral activation goals and think about any other.
So that would be like walk 10 minutes.
Yep.
Go to yoga.
Actually, yes. These are eat leafy greens. There's some great evidence from, Australia that might have some impact, positive impact.
Yeah. That's so similar to what I do too with ketamine, in that I find for my people with treatment-resistant mood disorders, the kind of therapy they need is really more behavioral. They need to move. They need to get sunlight, right? They need to be with people. They need to act like a healthy human, and that will help them be a healthy human.
Yeah. I talk to people about it as the fake it till you make it therapy. And sometimes folks will come in. Actually, this happens where I'm thinking of a particular person who is like, but I'm not feeling motivated. So how will it help me? I'm not enjoying it. How will it help me? But it's that idea from CBT of if your behavior is to sit alone for hours, the thoughts that you then have associated with that is, one, the cognitive distortions oftentimes are allowed to continue unchecked and unchallenged. But then you can also be quite self-critical about the period of time that you weren't productive or weren't doing the things that you are consistent with your values or goals. And then, the associated the worsening of the sadness, the worsening of the despair, the grief over lost opportunities, it creates that vicious cycle. So it's the idea, this fake it till you make it therapy, it's let's try to create a virtuous cycle where, maybe you hated the walk, maybe it was terrible, but later that night you're going to say, at least I walked 10 minutes. I did my behavioral activation. And when you come in the next day and we ask you, hey, how did that go? And you say, yeah, I got it done. It creates a different cycle where the thought is then, okay, I was able to do this. And then, really rebuilding that idea of your resilience and your ability to push through this really horrible time in your life. And that makes a big difference.
Yeah. Two things I struggle with when I think about TMS referrals. So again, let's say I have a patient that meds and or therapy have not helped, only partially helped. Maybe they've done ketamine. It's either not helped enough or stopped working. So I'm thinking about TMS. I've called the practitioner psychiatrists running different TMS operations on the Front Range, and I'll ask them these two things. So one is, how do I think about sort of protocol / machine? Because when I've called different psychiatrists in the TMS clinics, they'll say, oh, well, we have this machine, and we have this protocol, and this is the best. And then I call another one, oh yeah, well, we have this machine and this protocol. I mean, I have no idea what to tell my patients. And the other thing, and I guess this is a two-part question, is that how do I think about these different protocols, different machines? And then I've also asked a number of psychiatrists who run TMS operations, I say, who are the best candidates for TMS? So just to back up, so listeners are back from the abyss know that, the best ketamine candidates, at least in terms of mood disorder, have hypersomnic depression, seasonal worsening, early adolescent onset, severe vegetative symptoms, cognitive impairment, suicidality. So there really is a type of mood disorder that's very ketamine responsive. And I can tell those people, look, 85, 90% chance you're going to get better. Versus like the big bucket of treatment-resistant depression, which I think it's much less. So again, that's a complicated question. But again, how do I think about, I have someone I want to refer to TMS, and I Google TMS Denver, TMS Fort Collins Boulder, and there's all these different options. And how do I even think about if my patient is even appropriate? Am I going to have them drive all the way to Denver or set up shop in Boulder for 5 weeks and not get better?
I think this is it's the most salient question. And I'll answer the latter part before I talk about the protocols. Our typical patient has had 1 to 25 years of depression.
That's like our typical drinker is having 1 to 25 beers. But a lot.
It's a lot.
Because a year of depression is horrible.
It's horrible.
I mean, I'm giggling at this, but 1 year of depression is just awful. I mean, 25 years is unimaginable, except that you and I see that regularly.
And usually I think moving to TMS early. So if you've had a med trial and had partial response or no response, that's a time that I would even I'd ask practitioners to start saying, this might be somebody who's not going to respond to our first line medications. Many people do respond to first line medications. If they're interested and willing to trial one, I think it's a very reasonable thing to do. For a patient who's then tried a second class of medications and not had any response or partial response, that's a time I would definitely say we should really be thinking about TMS. The characteristics of people who have responded to TMS in our clinic, people who have pretty clear depression. It is depression. It might be secondary to other conditions or comorbid with other conditions.
What if it's secondary to trauma?
Secondary to trauma is actually the majority of our patients, I would say, have some form of trauma, either during their developmental years or currently. And I should go back to your question before about concurrent psychotherapy. So oftentimes when someone's had trauma that has not yet been therapeutically treated, we will recommend EMDR along with TMS. We won't necessarily delay our start of TMS, but we will say, EMDR could be a really particularly fruitful therapy to do along with the TMS that we're doing. And we've had some patients have really, really wonderful outcomes when we've combined the two.
So just to back up, good candidates would be someone with primary depression. So depression is the core issue.
It doesn't have to be the first part because it could be secondary to OCD. They could also have really significant anxiety, but it has to be clearly depression. So sometimes we have seen patients where the symptoms they're having don't seem so clearly to be a depressive response, and those are patients who I think would be less likely to benefit. So typically very clear depressive symptoms, some chronicity, some evidence that they haven't responded to other treatments.
Yeah. Any other prognostic factors, patient factors that would predict success? Because again, say with ketamine, severity of depression, severity of cognitive and vegetative symptoms actually seems to predict efficacy. Degree of sleep impairment, whether it's hypersomnia, insomnia, seems to predict ketamine success.
Right. So there are many, many demographic factors that do seem to have an effect. So female gender is predictive of response. Younger age, fewer years of depression. Though that being said, we see older individuals who've had 25 years and this is the first treatment that's worked. Not having a significant neurodevelopmental or neurodegenerative disorder, it does seem like in individuals who have significant abnormalities in their brain, modulating those functional networks becomes even more complicated. And I do think TMS may have potential in those populations, but our approved protocols aren't adequate to treat those populations at this time. Tiny caveat there where there is some great Alzheimer's research happening targeting the precuneus, and there are early studies that published on being able to delay or change treatment course in Alzheimer's. Very different than what we do in the depression or OCD treatment. And I know I'm kind of giving you a lot of details and you're trying to, and I would say we did recently publish an article in the Harvard Review where we talk a little bit more about the prognostic factors, demographics, treatment factors that can influence things. So from the broadest standpoint, younger individuals with fewer years of depression, female gendered people.
Female is interesting. I mean, younger makes sense. I think ketamine's more effective for younger people. Meds are more effective. Therapy's more effective. But female gender, that's very interesting. Yeah.
When we think about comorbidities, that's also another thing that seems to make a difference. And I guess I don't want to gloss over the female gender because it is interesting. The majority of our patients are female gendered. Though we see patients of all genders and we see good outcomes in patients of all genders.
But bipolar depression, no.
Bipolar depression right now, our current treatments are really geared towards major depressive disorder, and it's risky because of the very real risks of causing hypomania mania. There's great research studies that TMS is likely to be effective also in bipolar depression. That being said, right now our current FDA-approved protocol is too risky.
Yeah. I wonder if actually TMS could be very effective with bipolar depression, but you just need mania prophylaxis. Because I've found, one of the sweet spots for ketamine is bipolar depression, and even mixed state.
Right.
But I've found that you give someone a big dose of ketamine who's got bipolar 1 or, or a history of hypomania, and you don't have mania prophylaxis on board, you can throw them into psychotic mania. And I've done that 4 times in 8 years. But this is another frustration, is because, and I think part of this goes back to the way I think diagnostically. I definitely sort of am in the Nasser Gamey school of like, there is this primary endogenous depression that is kind of bipolar spectrum, but really we don't have a good name for it. It's, again, hypersomnic and early adolescent onset, and is lamotrigine responsive and ketamine responsive, and maybe TMS. But I think the last 3 people that I referred to TMS, in my chart, I had stuff about bipolar spectrum illness. And even though I'd never seen any true mania or hypomania, and they all got denied, they said, yeah, insurance won't cover that if that's anywhere in the chart. So that seems like a big limitation of TMS right now. I'm just assuming there's a lot of practitioners with people with bipolar spectrum depression that's treatment resistant, that we can't get them into TMS because insurance says no go.
Yeah. Well, and I would say so there is the piece of, getting access to care that does limit things. But right now, we just don't know enough about how to keep those patients safe in the treatment. So there's both kind of, an access problem, but then that clinical problem of the protocols just really weren't designed for bipolar depression. It is an active area of research. I'm hoping within, the next 5 to 10 years, potentially, that would be something that would have an indication and would know how to do it safely. Right now, I think we're just a little bit too early in the research phase to make that recommendation for those folks.
Clearly, especially after sitting here with you and meeting you, I want to send people to you for TMS. But, your Anschutz is in Denver. Most of my patients live around here. So again, going back to that second part of that big complicated question I floated a few minutes ago, which is this idea that as a practitioner, as a solo psychiatrist, I'm looking out there, I'm looking on Google, TMS Fort Collins and TMS, Denver and Boulder, and people are all talking about these different machines and different protocols, and what the heck? Like, I don't have any idea. And, I talk to them like, this is the best. This is the best. This is the best. Right. How do I navigate that?
That's an excellent question as well. And we have some advantage in the clinical space that for the most part, people will be using the FDA approved protocols, where there's really just 2 major types of TMS that will happen within the FDA approved protocols that are a more standard course, those 30 sessions with the 6-session taper, versus the accelerated protocols I'll kind of take separately. But the 2 major types of coils that are available now and FDA approved are the figure 8 coils. Those are a fairly simplistic design. It's 2 coils that overlap and we're able to maximize the stimulation where those coils that overlap in the center. And we have about a quarter-sized area where we get a really good, we call them E-fields, but an area where we can target. So we're getting very focal, strong targeting really in that specific quarter-sized location. That can happen with or without neuronavigation. The second major type of coil that exists are those broad coils. They're very complicated. There's 3 approved and available on the U.S. market that target different conditions, 2 of which are approved for depression. One has an approval also for depression and OCD, and then there's a third one approved for smoking cessation. The coils and the E-fields that the broad coils create, it's very complicated. We're targeting more of, I would say, a headband area of the cortex. We think of those as being bilateral, where we're targeting both sides of the brain at the same time. The FDA-approved protocols are still all excitatory for those broad coils. it is very different in the patient experience. Nolan Williams and Colleen Hanlon a couple years ago did a great debate about, broad coils versus figure 8 coils. A lot of the researchers prefer the figure 8 coils because of the specificity of targeting with neuronavigation. You know exactly what you're targeting and how you're targeting it. The broad coils really give you a really big advantage though. So if you're not using neuronavigation, that being said, in our clinic, we have both types of coils and we get excellent and analogous results across both. The broad coils, the advantage is that it's really hard to miss when you're targeting a whole headband. The area that we think is probably the area we need to most stimulate to get the neuroplasticity. So there's one particular area of the left dorsolateral prefrontal cortex that we think has the strongest connection to the subgenual cingulate. That's a small area under the genu or knee of the cingulate. When it's most anticorrelated or inhibitory, if we're stimulating that part of the cortex in the left dorsolateral prefrontal cortex, and the left dorsolateral prefrontal cortex, I should say, is huge. If we get to that one area, then it seems we're more likely to get an antidepressant response. This is based on actually work out of Mark George's lab in 2012 by Fox. It's really hard to miss that with a broad coil. It's easier to miss it with a non-neuronavigated figure 8 coil. In our clinic, we have a bit of a protocol where if someone's not responding with our initial treatment target and they're using the figure 8 coil, we might change the targeting. We might use a different scalp-based way to target. And we use a couple of different methods that are based on head measurements and most likely location of that hotspot.
So should I be asking these people when I call, are you using figure 8 or broad coil? And then if I ask that, I'm listening. It sounds like there are advantages of each, but maybe I'm looking for broad coil because that's. I think it can be good with either, and our outcomes are good with either. I prefer the more targeted coil for older patients. I think it's more comfortable, or for patients who have a lot of pain sensitivity, somatic sensitivity. I like the more focal targeting for those patients. If someone has OCD comorbidly, I do try to have them be seen on the broad coil. The broad coil has a slightly higher seizure risk. It's still incredibly low. It's 6 out of 10,000. So we're getting into those kind of like struck by a lightning statistics. But that is 6 times higher than our more targeted figure 8 coil. Those are only about 1 out of 10,000 patients will have a seizure. If there is anything in the history that makes me think this person's above the population average risk of seizure, it's not so absolutely high. I'm saying, I don't think we should do TMS, but it's higher than our typical patient presenting. I will try to put them preferentially on the figure 8 coil as well. So maybe I don't need to worry about these coil types. Maybe I can let the TMS experts figure it out.
I'd say it's always good to have a conversation, and hopefully whoever you're speaking with will give you, their rationale, why they think it's a good treatment, and not just, I know I'll lead with a lot of enthusiasm, but a lot of details about why they think it's safe or why they think it's effective.
Mm-hmm. What do you tell people, let's say treatment-resistant depression, in terms of response rates, remission rates, like someone sitting there, they're about ready to commit to potentially weeks of coming daily to get this treatment? What do you tell people? Yeah,
so in the literature, the early literature, the treatment response rate, and a responder is someone who has a 50% improvement by a validated depression scale, was about 50% of the patients. Now that's
50% of people get 50% better.
Yes.
Okay.
Yeah, thank you. Yeah, and that's early studies, and that's what's in the literature. We do get better outcomes in our clinic, and there's other things you can do with the treatment to try to boost those outcomes. And then the remission rates in those early studies, 30% of people having no more depression. Even though those are maybe discouraging if you're like, okay, I have a 1 out of 2 chance of getting better, those even early on, those rates that are not as good as modern TMS were still pretty impressive because when we're thinking about another medication trial, that's someone who has a less than 3% chance of improving with another medication trial. The things that have been studied that seem to definitely improve outcome, so doing it with psychotherapy, we feel really committed to that in our clinic, as we talked about. One of the early studies by Dance in 2018 showed that they got about a 10% increase in who was a responder over those early studies using just the addition of psychotherapy. And their remission rate jumped all the way up to 56%. So you get to about half of the people going into remission just with the addition of psychotherapy. For neuronavigation, a similar sort of jump was seen when Stubman looked at that in 2018.
Maybe you could explain that, neuronavigation.
Yeah. So neuronavigation it's an important part of some of the accelerated protocols. And it's a very important part when our researchers are saying, we know exactly what we're targeting and how we're targeting it. We take MRIs and we actually upload them to the device that is doing the TMS. And we can look both structurally and at different tracks at where we're targeting the actual stimulation. So it's uploading that MRI data and being able to target off of the MRI data individually. And that increases outcomes. Stubman, when he studied just that piece alone, that brought the response rate to 72%. So we're already at 3/4 of the people about then responding. Nolan Williams, when he did Zinc, he put many different things together. So they used shorter protocol and intermittent theta burst. They combined it with many, many, many treatments a day. And then they also did use a neuronavigation. And that seems to be the special sauce that led Zinc to be so effective in the really short time frame that they showed.
Yeah. Yeah, my understanding is that what Nolan Williams showed the world is that TMS is better if it has neuronavigation, if it's guided, and if it's more intensive, stacked on top of each other. And that's actually what got me, as I said a few minutes ago, what got me increasingly interested in TMS. This might be interesting. Let's imagine that you and I are each trial attorneys and we're making our closing case. So this might be fun. What's your case for TMS as the next step after depression that's failed medication and therapy treatment? And then maybe I'll make a ketamine case. But so again, this sort of, you and I are going to go TMS versus ketamine. Why do you think TMS should potentially be the next step?
This is a great leading question. I do think TMS is always my next step recommendation. What we see is in our clinic, our response rates are higher, even with no neuronavigation. With the way that we do it, about 75 to 85% of our patients leave our 6-week, 7-week treatment feeling substantially better. So we're able to get really pretty good results really quickly in patients who have not responded to other things. Our side effect profile is incredibly benign. So I mentioned seizures, and we have to talk about seizures as our scariest potential side effect. There's also hypomania, mania if we diagnostically were wrong and it's not a clear-cut depression. And then the other two side effects we have to talk about is about 30% of people have a worsening of tension type headaches early in the course. Usually gets better, and our migraine sufferers even report improvement in migraine usually by the end. And then it's not the best sensation. It's uncomfortable. It's not exactly painful for most folks, though a few folks have found it exquisitely painful. That's usually when there's an underlying pain condition and more pain sensitivity.
Do you think of TMS as being more effective or just more, better tolerated?
It's incredibly well tolerated and it's incredibly durable. So after those 7 weeks, we usually don't have to see people back for a while.
What's a while?
The durability studies that are published for some of the broad coils, they say about 87% of people with no further treatment remain doing as well as they did on the last day of treatment at a year. We see even better results in our clinic, where we've treated about almost 200 patients now through a full course over the last few years, and we've had about 11 patients come back. Usually the patients who have come back have had a really significant loss or traumatic experience. That seems to have set off the next depressive episode. Some patients who have had a really extreme caregiving burden. And so, with no further treatment, having a few years of not having depression is, I think, really worthwhile.
Yeah. Okay, that's a pretty good case. I'll just make my quick ketamine case.
Yeah.
I think I'll cede you the durability thing because that is the big problem with ketamine. Ketamine's super effective. In general, it's well tolerated. It works really fast, but durability is a big issue. I think maybe where ketamine might beat TMS is you can have a suicidal or basically non-functioning patient in your office, and you can do a ketamine treatment or two, and 36, 48 hours later, they're way better, sometimes all the way better, sometimes totally euthymic and shockingly better. But durability is the big thing. I also wonder too, maybe we could transition to this. Access seems really difficult because I can have someone in my office who I'm really worried about. I can walk them 12 feet down the hall. We can put them in a chair, we give them eye shades and music, and we put them in IV and we send them into the K-hole, and I can treat them right there. Whereas, gosh, with TMS, I'm like, okay, where did they go? And then there's, TMS is very expensive because it's over 6 weeks, so you got to get insurance to pay. Otherwise, they're looking at $10,000 or $15,000 out of pocket. So there's that, and there's records, and there's this. And it's a whole process. It's kind of like getting people into ECT. Yeah. Again, I do send people to ECT, but each time this is such a process. Where ketamine is easy peasy.
Yeah.
So, do you have any thoughts about accessibility or what we can do to try to get this treatment more available? Because again, it crosses my mind a lot, but I often think oh my gosh, where do I refer? How do I do this? This is going to be a long time. Is insurance going to pay? Oh my gosh, did I put bipolar ever in the chart? They're going to freak out about that.
Well, I think, firstly, it's just incredible to think about. You can take someone at that moment of crisis and in 48 hours have them feeling euthymic. It's an incredible thing. I think what you're highlighting is, I do think the way that we use ketamine and TMS is different, and at different points in the depression, and maybe with different focuses or expectations around what we're hoping for. So if I had someone who is in acute crisis in my office, usually we're not trying to move to TMS. TMS is going to work over time. The cumulative effects over 7 weeks is what gets us the benefit. But again, going back to that neuroplasticity, the moment of crisis is not the time that I would move to TMS. It is exactly the time where I might be referring people to you and saying, actually, I have somebody who needs IV ketamine right now. And access is hard. The cost of it's a real barrier. Getting coverage, being able to show that people have done the fail first models that are currently in a lot of the major payers' requirements. It's a big process. It takes us, on average, I would say 3 to 4 weeks from when we get a referral to when we might be able to start someone. And that's really because we've worked so hard to optimize our process at the university that it might take a month. For some folks who have more complicated cases, it may take longer.
Hearing you talk about durability with the standard TMS protocol, and again, durability meaning people getting into remission, staying in remission. I wonder if maybe we're asking the wrong question. So I was positing this ketamine versus TMS question.
Right.
It might be that they actually are best thought of as complementary, because maybe someone is in our office and they're profoundly depressed, non-functioning, hopeless, suicidal, and we're using ketamine to pull them out of the hole quickly and keep them out of the inpatient unit. And then once they're stabilized with, say, maintenance ketamine every 4 to 6 weeks or whatever, then we're scheduling TMS to get them into a durable remission.
Yeah.
It kind of reminds me what I'm seeing more and more with my patients with who are doing ketamine and then also adding psilocybin treatments. So a lot of my patients are doing ketamine for their depression, which often has trauma roots. So the ketamine is getting them so they can function, take care of their kids, and go to work. But then they're doing psilocybin-assisted therapy to really get at the roots of trauma. And so then what we're finding is they're needing ketamine treatments much less frequently because overall the sort of trauma fuel of their depression is dialed way down. So again, more and more I'm thinking of ketamine and psilocybin as complementary. And this is interesting. I'd not ever thought really of TMS ketamine. I mean, I have some people that have done TMS concurrently with ketamine, but the way you describe TMS, and this makes a lot of sense to me. Because again, I'm often thinking about TMS when people are doing really badly. It's like, oh, we got to do something for them. But it's a longer project. It's a project where people need to have some level of kind of functionality and stability to do it.
Yeah, I do think I would agree with you. I think that's exactly the sweet spot. And we're pretty excited about psilocybin too. At the university, we have a couple of the research studies. It does seem like another one where people have more durable remissions with the psilocybin, with our TMS. I should comment on the durability of the accelerated protocols. That was actually the reason the accelerated protocols were developed, was to try to address the fact that sometimes we want to have something that's available when someone's in crisis and works under a shorter time frame. But similarly, they just don't have the durability. So, and actually Nolan Williams has, I know we're referencing him a lot. He
deserves it.
He deserves it.
Yeah.
He was incredible. He described the development of SAINT and the intervals he chose to be able to stimulate as the intervals that were based on the data from learning theory, how often you should try to stimulate the brain to actually have a durable effect and to be able to give time for the brain substrate to recover between the stimulations. So that's where the hour came from. There is some research and work on, could we make that shorter? Could it be a half an hour? Should it be longer? Should it be 2 hours? But when he talks about it, he talks about it as we're cramming. You know, we're teaching the brain, but we're cramming. And I think that's the exact right analogy between standard TMS and the accelerated protocols. The accelerated protocols work much faster and they work well. And I would say equally well to the modern standard TMS that we have, but they suffer from durability problems. The standard TMS takes a lot longer, but then we get this incredible durability. They've tried to address the durability issues of the accelerated protocols. Actually, the company that has kind of developed further his work with the accelerated protocols has a wearable now that patients keep and will detect when they're having a recurrence of depression. It's proprietary how they detect it. I suspect it's probably tracking motion and movement and heart rate variability, maybe autonomics, maybe temperature changes. They don't publish it, so I don't know. But they do have people come in for booster sessions when they have a recurrence or they're suspected of beginning to recur in their depression. And so that's one way they've tried to address that. But I think exactly to what you highlighted, it's going to take all of the new interventional therapeutics and figuring out when we use them and for what patients and who's going to respond to ketamine and who should we be sending to TMS and at what point in the treatment course. And that's how we're going to move the field into, I don't know, maybe phase 4.
I just had an image of this little menu. We do an evaluation. This is Psychiatry 3.0.
Yep.
And on the menu is psychotherapy, trauma therapy, TMS,
Yep.
mushrooms, ketamine,
Yep.
MDMA. You go, okay, you need A, B, D, and E.
Mm-hmm.
Yeah.
And for different people at different
Right.
moments.
I see a lot of OCD, BDD, and it's really become apparent to me, and I think the literature supports this, that ketamine really doesn't do anything for OCD. Now, if you're super depressed with vegetative symptoms because of your OCD, or if your OCD is coming as a trauma response, I think ketamine can really help. But if you have sort of straight up DSM, kind of inherited endogenous OCD, it doesn't seem to do anything. What about TMS? Like, tell me about TMS and OCD.
So we have an FDA approval for OCD using our broad coils. Actually, some of the figure 8 coils have now added on approvals as well over the last few years. The first approval was in a broad coil, and that's the one that we can offer in our clinic. So I know that protocol best. That was first approved in 2018. And the data it was improved on was about a 30% improvement in the Y-box score. Now, we think of OCD, or at least I've been taught to think about OCD as a problem that has more chronicity, where our goal is not always remission, it's management. And a 30% improvement in a Y-box is really clinically significant. It can take someone from the extreme range down to the moderate range, where they're living, they're functioning, they feel pretty good, and that they can go through their days and do what they want to do. In our clinic, we've had a number of patients who have had both, who have had comorbid MDD and OCD. And we do ERP, again, when we're neuroplastic, what we're doing matters. We develop an ERP protocol along with our OCD colleagues.
Which is exposure and response prevention.
Yes,
Yep.
yes, thank you. Oftentimes with our OCD colleagues at our OCD center on the campus, or with the OCD therapist who's working with the patient, if there is one. If not, then we can develop in our clinic and we get it reviewed if we need it but we've had some incredible outcomes where patients have had much more than that 30% reduction. Some patients have benefited less. There is variability, but it does seem like when it is a really clear OCD without a lot of comorbid influences, TMS is actually quite helpful at modulating that striatothalamo-cortical loop that we think is...
Is that durable, the effect?
Yes. It's similarly durable.
Yeah, interesting.
Though
well, that's good to know.
I hedge a little bit because I think there's a bit more fluctuation around that baseline than the question of remission for depression.
One of the things I love most about ketamine is there's so many patients that I see, I assume that you see too, where they're sitting on my couch and I'm thinking, okay, you have some mix of mood disorder and trauma. And again, those things track along and follow in generations. And it's often really hard to tell like how much we're treating mood disorder and how much we're treating trauma. And one of the things about ketamine works for both. Like, you know, most psych meds don't do anything for trauma, but ketamine works beautifully for both. But how do you think about that, you know, complex patient, again, with trauma and potential mood disorder? Does TMS work for both? And again, maybe more specifically, do you think of TMS as a trauma treatment?
There is work looking at investigating TMS specifically for PTSD with some good results. The way that I think of it, for patients with a comorbidity, we're able to get a very good response if usually they're in the trauma-focused treatments as well. I don't think of TMS solo as the right response if there's a lot of trauma symptomatology, but I think it's a really important adjunct. And especially for patients who have had chronic developmental trauma, especially emotional abuse, neglect, and their depression seems to have a lot of persistence. It does seem like they have really great outcomes with depression. And, you know, going back to what we know about the genetics and the potential brain changes that can result from those exposures, I do think it makes sense then TMS is able to mechanistically work differently for folks whose depression has a lot of roots in their childhood or in traumatic experiences.
You know, there's some really interesting data that one of the things that ECT is doing is helping meds work better. And you may be aware of some of this research that if you get people better on ECT, electroconvulsive therapy, and you pull their meds away, they relapse quickly. But if you stay on their meds, they do much better. And my experience with ketamine has been the same. I've talked about this on the podcast, that ketamine's doing a bunch of things in the brain, but it does seem to potentiate meds. A lot of people come and their goal for ketamine is to get off their meds. But I say, look, maybe we can get your meds to work better. Do you have a sense with TMS? Like, is TMS also a treatment that is helping meds work better, or is it actually making it so people don't need to be on as much medication?
Yes. And I know that's a cheeky response. No. So I'll clarify. We have patients who come on medications, and we have patients who come who have discontinued medications because they've had such discouraging results. Whatever way people come in, I ask them to kind of formalize what is their ideal regimen before we start the TMS. If it feels like meds are important for safety, if they're telling me there's someone who's a partial responder, then we might encourage them to continue those and not try to discontinue those before trying TMS. If they say, really, I'm getting no effect, and they've either come off with their provider or they want to trial coming off, that's the state at which I say, okay, let's try the TMS with whatever regimen you have. I don't want anyone to shake the boat right after TMS. Some of the evidence does suggest that being on medications with TMS is helpful, and we're more likely to have a treatment response if you're on medications as well. If we get a treatment response, though, I want people to keep things as similar as they can for the 6 months to a year after, because we've allowed for that neuroplasticity, this new functional connectivity. Let's not rock the boat, because you've got this response with your medications, with the therapy, with TMS. So the last thing I want you to do is a month after come off of the medication, because that could precipitate a pretty acute return of the depression. We have had that happen a time or two where someone has come off a medication after a course and then had a recurrence.
So as I'm starting to summarize here what we've talked about the last few minutes, and this is actually really interesting for me to think about, that, say, the SAINT protocol, which is the accelerated TMS, that actually maybe is a little more ketamine-like because it's getting people better fast, but it has the durability problem, which ketamine has. But standard TMS, which is daily over 5-6 weeks, while it takes a while to get people better, it can keep people better in a way that maybe the accelerated TMS and ketamine struggle to do.
That's been my experience.
Yeah, that's really interesting. What about TMS for treatment-resistant psychotic symptoms, like people who are still having auditory hallucinations or delusions? I mean, is there ever a role for TMS in that?
Probably. It's again another active area of research. So Michelle West at the university, who runs our program focused on early access for prodromal or early psychotic symptoms, it's an area where she and I have talked quite a bit about positive evidence that you can use TMS to modulate specifically auditory hallucinations. It's pretty robust evidence that it works. The problem is we don't know for how long. We don't know how durable it is. And there's not a lot of safety parameters around, is this working well enough that someone could be in the community, or is this working and helpful, but they should be inpatient? And so that's one of the areas that would make it hard to offer right now, because even though we have evidence it could help, we don't know specifically how we should do it, what the durability would be, and what the safety around it might look like. But it's a really active area of research.
But not something that I would be like referring patients for yet. Okay.
Not yet. And there's, just to kind of piggyback off that, there's also some deep brain stimulation work that actually may have more clinical utility, because that's a treatment that would go with the patient. You wouldn't necessarily have to worry about them missing an appointment or compliance. The deep brain stimulation studies that are out of Johns Hopkins, really, really fascinating. We've been trying to actually do some of that work here at the university. Rachel Davis, Judy Galt, they're actively interested. We have a an investigational device exemption application that they've been working on to try to trial that on some of our patients.
Yeah. One final question as we're wrapping up here. What are you most excited about in this sort of Psychiatry 3.0, TMS, neuromodulation?
I think I'm most excited. I guess it comes back to the idea of, and this is actually an area where I see my next 10 years being focused on how do we clean up our diagnoses? How do we actually identify what type of depression this is? What is the actual underlying etiology? And then how do we translate that on the individual level, getting that person to the right treatment at the right time? So this comes a little bit from my work in precision medicine, but this idea of the, right intervention, right person, right time, that's what we don't have yet in psychiatry. We end up doing all personalized medicine in psychiatry because we do have so much treatment failure. And we need to be better able to differentiate different subtypes of depression. It's not a monolith. We treat it as a monolith, but so many different subtypes of depression walk through my office every week. Being able to say your type of depression is this type of depression. It feels like where we're at diagnostically is how cardiology was in the 1900s. You have heart failure. Okay. Well, yeah. Why? Why do I have heart failure? And until we can answer that, until we can look and we have the biomarkers and we have better diagnostic clarification, it ends up relying on the individual clinician. I know you and I were talking earlier too about, we just know. A patient walks into your office, we have enough experience now where we can say, this is the treatment that I think will fit you. Mm-hmm. That is really deep pattern recognition that we've had to develop on the individual level and in this personalized medicine space because we don't have great algorithms and we don't have great diagnostic clarity. An experienced psychiatrist can do that. But we need to have this translation where less experienced psychiatrists.
Right. It needs to be systematized.
Yeah, PCPs.
Right, because now we're all kind of our own individual experts relying on tens of thousands of hours of patients.
Yep.
Yeah.
Yep.
Yeah, I wonder if part of Psychiatry 3.0, part of it has to become having a meaningful way to talk about root causes and etiology. And one thing I've just been thinking more and more about, again, psychiatry is starting to wake up to this, but this idea that there is a subset of depression, especially treatment-resistant depression, that is profoundly linked to the immune system. Mm-hmm. And so just a couple of things to throw out there. So one of the things that's so interesting is when you use ketamine at psychedelic doses on people with autoimmune disorders.
Right.
Crohn's, anything. Like I have a bunch of people with autoimmune illness, ulcerative colitis. They often get a few days, a week of significant reductions of symptoms. Mm-hmm. So clearly ketamine is doing something with the inflammatory response in the immune system. Another piece of evidence that I've talked about before on the podcast is that it's really interesting that a lot of the biologics work for about a month. Mm-hmm. And ketamine maintenance for people with really serious treatment-resistant depression lasts about a month. I mean, when I think of ketamine maintenance, I think like a lot of people, it lasts about a month. And then I heard a podcast recently about TMS. I can't remember who was talking, but the person was saying that accelerated TMS, even when it works, gets people to remission, that you need to do monthly booster sessions. It just hit me. I think, wait, that's true with ketamine. That's true with TMS. Mm-hmm. We are seeing that a significant percentage of our people are getting an anti-inflammatory immunomodulating response. How soon until psychiatrists actually, we're starting to do some kind of, some kind of immuno panel, something, and then we say, oh, not that you have MDD, because that's a meaningless diagnosis. You have this sort of inflammatory autoimmune something that's going to suggest, strong ketamine response, or I don't know. I think we're getting there. I'm really hoping that's going to fold into Psychiatry 3.0.
I'm gonna go off the map here a little bit and say,
go for it.
I deeply, deeply agree that I think there is a piece that inflammation explains in our population that absolutely has been unrecognized. I say off the map because I never like to say big sweeping generalizations like that unless I can quote the exact study. And right now we just don't have those studies. But I do frequently recommend that people take fish oil along with the treatment. If we're thinking about supplements, if people ask me supplements, I think the data that we have on fish oil is so much stronger, especially the high dose EPA, DHA, than other supplements. Maybe turmeric, maybe ashwagandha, but really fish oil has been very well studied. There was a great Nature paper actually looking at fish oil on the vulnerability to psychosis and the development from prodrome to full psychotic symptoms. And it was 40% protective. That was a paper out of Italy. I believe it was 2016. Just amazing results. I don't know a behavioral health pharmacist who doesn't take fish oil. It's
Interesting.
It really seems to have dramatic impacts, potentially also on mood, anxiety. We think of oftentimes the cardiovascular protective effects too being putatively anti-inflammatory. We don't have those linkage studies yet, but I agree with you 100%. I'm fascinated by that timeline and the fact that you've seen that improvement in your patients with disorders that we think of as is really responding to those monoclonal antibodies, to some of the more of the biologics. I do think it's a big piece. And part of the research I'm interested in doing over the next 10 years, some of the areas in the brain that I think TMS is working on. And we have some of this data from Helen Mayberg's depression studies, seems to be particularly vulnerable to inflammation, to that HPA axis dysregulation. But again, these are a lot of pieces. We don't have the allied studies to say it, but I think you're right.
Well, it's been so enjoyable. I've learned it. I've learned a ton. And actually, I think I can more confidently refer some people now.
Oh,
Yeah.
thank you.
I want to send people to you.
Okay.
Just have to say, just got to drive down I-25, maybe get an Airbnb near Anschutz and just hole up there for 6 weeks.
Yeah.
Yeah. Well, thank you so much for coming.
Thank you again for having me. I'm excited to be here, excited to educate and hopefully get some folks who didn't know about TMS into TMS if they need it.
Yeah. Thank you. As I began to listen to the final edit of this episode, I suddenly got this sad, sinking feeling in my gut when I realized that I had not spoken the truth of Nolan Williams' recent death. I only alluded to him being gone by referring to him in the past tense. Dr. Nolan Williams, truly one of the most important thinkers and researchers in psychiatry, he died this October by suicide. I think it's so important that we don't gloss over this heartbreaking fact. We need to speak the truth that sometimes the healers are hurting as much as the people who they are trying to help. We don't come to this work by accident. We are all trying to find a way to heal something deep within ourselves, and sometimes we just can't find a way out. And now, my main takeaways from today's episode. TMS, I think, is perhaps best seen not as an alternative to antidepressants or to ketamine, but rather as a way to effect long-lasting changes in the brain, which then become the substrate for better mood regulation. I was pushing Dr. Fenstermacher to try to make the case for TMS over ketamine, but now as I think back on our conversation, I'm realizing that she changed my mind, that I now think of TMS as a complement to ketamine for treatment-resistant depression. Ketamine to pull people out of the depressive hole and stabilize them. Then TMS to produce the durable changes in the brain, which might reduce the need for ketamine or other antidepressants over the long term. Along these lines, I was also surprised to learn that rapid-acting TMS, also known as SAINT, S-A-I-N-T, it appears to sacrifice the longer-term durability of standard TMS for its rapid onset of action. I just love Nolan Williams' idea of Psychiatry 3.0 as moving into neuromodulation. And as I suggested in this conversation, maybe Psychiatry 3.1 is neuromodulation plus psychedelics and psychotherapy. I wouldn't be surprised if most psych meds steadily disappear over the next 10 to 20 years, that we'll look back on this era of oral psychiatric medications as being kind of quaint and strange and even primitive. You can support Back from the Abyss in 3 ways. You can contribute to the out-of-pocket costs of the podcast by clicking on the Support the Show link in the show notes. You could write us a review in your favorite podcast platform, and you can share a favorite episode with someone who you think might really benefit from hearing it. We'll be back in 2 weeks with a story about addiction and recovery, one told from a perspective of a nurse caught up in a terrible spiral.